Good morning, everyone. First of all, I would like to thank the organizers for this opportunity. So I'm here to present 4 interesting abstracts. First is on chemotherapy-induced peripheral neuropathy, prevention trial in patients with breast cancer on taxane-based chemotherapy using either hand cooling or compression technique. Now, we all know that this peripheral neuropathy is a dose-limiting side effect with taxanes, and there's no established strategy how to prevent this. There was some hypothesis that cooling or compression can help. So this was a simple design. 122 patients divided into 2 groups, 61 each. The patients on cooling dominant hand technique. So the dominant hand, they used a frozen glove, and the control arm, the hand was free. The other subset, the dominant hand used a compression technique. So in this, 2 surgical gloves were put on the hand. The size of the glove was 1 size smaller than the tight-fitting glove. And the control arm was a free hand. The patients received weekly nab-paclitaxel for 12 cycles, and the assessment was based on these criteria. Looking at the results, cooling or compression, what they saw was there was a 50% reduction in the grade 2 or more chemo-induced peripheral neuropathy. Comparing cooling versus compression, there was not much difference. So to conclude, POLAR is the first trial to compare cooling and compression for preventing CIPN. Both interventions were highly effective and almost halved the risk of grade 2 or more CIPN. Compression is easily accessible and inexpensive and better tolerated. It could play an increasing role in clinical practice and should be further investigated in clinical trial. Discussion and comments. So it's a very common side effect, difficult to handle once it sets in. So it's important to take care of it while on chemotherapy. If you look at the dropouts, in the cooling group, there were 9 dropouts, and the main reason was intolerance to the frozen glove. Look at the compression group, there were 12 dropouts, but only 1 was because of intolerance. Hence, compression was better than cooling. Regarding the use of dominant versus non-dominant, now we've been taught that peripheral neuropathy is symmetrical, but what if it is not? So this is little kind of a caveat in the study. Again, the definition of grade 2 adverse event. So the definition is kind of subjective, moderate symptoms, limiting self-care activities. Here again, this definition is little subjective, another caveat. Numbers are small, pilot study, but of course, something to offer. I would personally prefer compression over cooling because of easy availability. Abstract number 2 is on supplement therapy. So omega-3 in the treatment of mood or sleep disorders induced by hormone therapy in women with breast cancer. It's a randomized, double-blinded, placebo-controlled clinical trial. Background is that long-term use of hormone therapy poses serious side effects such as hot flashes, night sweats, mood and sleep disturbances affecting quality of life. Omega-3 supplement contains PUFAs, and we all know that the important part of the cell membrane, which is key to healthy cell structure and function. The study was performed to investigate the effect of omega-3 on the treatment of mood and sleep disorders induced by menopausal complications due to hormone therapy in patients with breast cancer. Study design was that patients which are hormone-positive breast cancer, stage 1 to stage 3, who've undergone surgery, received chemo plus minus radiotherapy, were divided, they underwent a hospital anxiety and depression scale scoring. So anyone with a score more than 11 were then randomized into 2 groups. One received omega-3 capsules in a dose of 2 grams per day. The other received an identical placebo. They were assessed at the end of 4 weeks using a Center for Epidemiological Studies depression scale, profile of mood states, and Pittsburgh Sleep Quality Index questionnaire. The assessment showed that most of the parameters had improved. If you look at the 2 groups, intervention group above and the control group below, if you look at the parameters, in the intervention group, all the parameters show improvement with a significant p-value, whereas in case of the control group, there's no improvement. So this study showed that omega-3 supplementation can improve mood and sleep disorders in women suffering with breast cancer while they were managing with anti-hormone drugs. Omega-3 has the potential to reduce mood disorders as well as to improve sleep quality and duration of sleep in patients with breast cancer. There is paucity of data because we don't know the exact mechanism of action. The sample size was small and short duration of study, but the good thing is that study did not have any side effects. So omega-3 did not have any side effects. It's a supplement with a proven benefit, so can be considered before referring a patient to a counselor. And just a 4-week therapy, so you can put a omega-3, if no improvement, can be referred. Coming to abstract 3 is the effects of vaginal testosterone versus placebo on female sexual functions. It's an interim analysis of the pivot trial, that is prevention of the recurrent UTI infections using vaginal testosterone. Background is that postmenopausal women experience changes in vaginal flora, vaginal atrophy, that have been associated with declining estrogen levels. Vaginal estrogen treats atrophy, thereby restoring flora. which prevents UTIs and improves sexual functions in postmenopausal women. We've seen that vaginal testosterone cream has also shown improvement in the vaginal atrophy. So this study was done to determine if vaginal testosterone is more effective than a placebo cream in restoring vaginal flora, improving vaginal health index, and sexual function of postmenopausal women with recurrent UTIs. These are the two scores that were used. First was the vaginal health index score, scores from 5 to 25, the parameters of vaginal elasticity, secretions, pH, epithelial mucosa, and hydration. Other was the female sexual function index, range from 2 to 36, which involves desire, arousal, lubrication, orgasm, satisfaction, and pain. Study design with 44 number of patients. So postmenopausal women with recurrent UTIs, the two assessment scales of vaginal health index score and the female sexual index function index were randomized into vaginal testosterone versus placebo, and the assessment was done at 1 month and post 9 months of the treatment. If you talk about the vaginal health index, if you look at the last line, which shows the vaginal health index score, it started with 14.65 and improved to 17.5, which is statistically significant at the end of 9 months. Talking about the female sexual function index, patients who received vaginal testosterone versus placebo cream, actually both the groups showed improvement, especially in desire, lubrication, orgasm, and pain. So to conclude, initial data demonstrates improvement in vaginal pH and vaginal health index after 9 months of treatment with vaginal testosterone. Improvement in sexual function score were also seen in both the treatment and the placebo groups. High patient enrollment and longer treatment follow-up will be valuable in understanding the effect of vaginal testosterone versus placebo on sexual function amongst postmenopausal women. Discussion, women using placebo cream also had improvement in the female sexual functional index. This may be because there were more women in the treatment group lost to follow-up and fewer who were sexually active. Women generally are reluctant to treat vaginal atrophy and sexual dysfunction with estrogen because of perception that estrogen can increase breast cancer risk. Control arms should have used estrogen for a better conclusion, because here it was testosterone versus placebo. And because patients are reluctant to use estrogen and we have an option of testosterone, so we can give that option against testosterone and can be freely discussed. Coming to abstract 4, this is characterization of alpelisib associated hyperglycemia in metastatic breast cancer. For women with hormone receptor positive HER2 negative breast cancer and PIK3CA mutation, alpelisib plus fulvestrant improves progression-free survival. Hyperglycemia is a major toxicity of PIK3 inhibitor, including alpelisib, which may limit its clinical efficacy. This was a retrospective study from MSKCC. From 2013 to 21, data was taken from the medical records. Looking at the baseline characters, around 247 patients, more than 50% had the baseline BMI of kind of overweight, more than 25. HbA1c of around 40% was in the pre-diabetic or diabetic range. Interestingly, 32 patients were HER2 positive. Looking at the results, the median time to onset of hyperglycemia was 16 days. 61.5% of patients developed hyperglycemia of any grade. 29.2% developed hyperglycemia of grade 3 or grade 4. This important BMI of more than 25 mg per meter square or HbA1c of more than 5.7 were highly predictive of developing any grade hyperglycemia, especially grade 3 or grade 4 hyperglycemia, which was statistically significant. These set of patients also were strongly predictive of alpelisib dose reduction or discontinuation. 27.9% required only one antihyperglycemic agent, whereas 3.6% required more than 3 antihyperglycemic agents. 19.8% were referred to endocrinology consult, which was associated with SGLT2 inhibitor prescription. 17% required alpelisib dose reduction and 4.5% discontinued alpelisib due to hyperglycemia. There was no significant difference in PFS by hyperglycemic grade. To conclude, BMI in the overweight, obese range and hemoglobin HbA1c of pre-diabetes or diabetes range was strongly predictive of developing alpelisib-associated hyperglycemia. And alpelisib dose reduction or discontinuation due to hyperglycemia. Management of these comorbidities prior to alpelisib treatment should be strongly considered. So, handling alpelisib hyperglycemia is a headache. This is just a retrospective analysis, but still, 247 numbers is a kind of a significant value. We can be extra cautious with patients with high BMI or high HbA1c, can have a low threshold for dose reduction in such patients, and there's no effect on PFIs. So, is a lower dose sufficient in such patients? Thank you.